Assalamu alaikum. Today we have Dr. Naghman Zuberi, and the topic of our presentation would be Etiology of Malocclusion. Sir, we have gone live, so we can start the
Yeah,
lecture.
sure. Welcome again. And today, as we have promised, we will be discussing etiology of malocclusion. So I have actually divided this into two parts. It's a quite a long topic. So today we will be doing its part one. So let's start with our today's lecture, etiology of malocclusion, part one. Well, the first person who explained normal occlusion was John Hunter. In 1771, he explained the normal occlusion in one of his books. After him, so many other people they came, but the recorded history it says that there was a person, a surgeon by the name of Fitch. He was the first one who explained the malocclusion or who described the malocclusion. Malocclusion is a misalignment or incorrect relation between the teeth of the two dental arches when they approach each other as the jaws closed. We know that Edward Engel, like the father of the modern orthodontics, we consider him that he considered that the first two, like at the moment we say that the way he explained the malocclusion, which is still prevalent and we are following it, he based his classification on the relative position of the permanent maxillary first molar. Just for your revision, I know that all of you are aware of these, the class 1, class 2, and class 3. So class 1 malocclusion, the mesiobuccal cusp of the upper first permanent molar occludes in the buccal groove of the lower first molar. All of us are familiar with it. And if you remember, I told you in one of my lectures that Edward Engel never told us about the angulation of the tooth. He never told us about the mesiopalatal cusp or the distopalatal cusp where they are occluding. But having a class 1 molar relationship, it does not mean that everything is normal. It is only giving us the information that molar relationship is class 1. It could be crowded arch. It could be an arch with spacing. There would be some missing teeth. There would be some rotated teeth. Or even at times, there would be a chance of maxillary protrusion with class 1 molar relationship. Or there would be a chance of bimaxillary protrusion or bimaxillary prognathism. So there are a lot of variety which is present in class 1 molar relationship. Anything is possible. Yes, if there is no any crowding, there is no any spacing, and canine relationship and incisal relationship all are class 1, with the skeletal relationship class 1 as well, and without any bimaxillary prognathism or bimaxillary protrusion, then we will consider it as a normal occlusion. Well, class 2 malocclusion, the mesiobuccal cusp of the anterior, of the first permanent molar is anterior to the buccal groove of the lower first. We are talking about the mesiobuccal cusp of the upper first permanent molar. It is anterior to the buccal groove of the lower first permanent molar. Well, this class 2 malocclusion, we can see it over here. It has two subtypes on the basis of inclination of the maxillary anteriors, div 1 and div 2. Div 1 means the upper incisors are proclined and there is an excessive overjet. Whereas class 2 div 2 is a situation where either all the incisors are retroclined, if not, then the central incisors are retroclined and lateral incisors are proclined. This is basically a very typical type of class 2 div 2 where the central incisors are retroclined and the lateral incisors are proclined. with molar relationship class 2. Class 3 malocclusion, when the mesiobuccal cusp of the of the first permanent molar is posterior to the buccal groove of the lower first permanent molar, like this. Well, at times, because of some premature contacts and some other occlusal developmental problems, there would be a chance of hyperpropulsion of the lower jaw, because teeth cannot stay in, you can say, the inclined relationship or cuspal relationship. They need for stabilization a cusp fossa relationship. So in that attempt, if they are like the lower jaw is moving forward, so it will be a pseudo class 3 or functional class 3. We also call it functional anterior crossbite. There are subdivisions as well, like class 2 and class 3 subdivision right or subdivision left. So they are based on unilateral molar relationship. One side will have class 1 molar relationship and the other side will have class 2 or class 3 molar relationship, and that will be designated accordingly. Usually it is because of crowding, or it could be because of premature loss of the deciduous teeth. So over here in this case, we can see that it is class 2 subdivision left. Here on the left side, we can see that the molar relationship is in class 2, whereas on the right hand side, the molar relationship is class 1. So such a condition will be called class 2 subdivision left, and we designate the malocclusion on the side. The name is like the condition is going to be designated on the side where it is occurring. Here it is occurring on the left side, so we will call it class 2 subdivision left. Similarly, here in the class 3 relationship, on the right hand side, we can see that there is class 3 molar relationship. This is upper first permanent molar. This is lower first permanent molar. So they are in class 3 relationship. Whereas on the left hand side, we can see that the molar relationship is class 1. Well, it's been over 120 years we are following Edward Engel's classification of malocclusion. And still we are, like, it's been continued and we are following it. It is basically the main language, or you can say the main classes, or the standard of classification of malocclusion among the orthodontic specialists worldwide. And though there is a lack of verifiable scientific validity, we are not sure that it is really normal or it is not normal. There is no any scientific validity to whatever the Engel has proposed. Though an arbitrary or subjective concept of ideal occlusion based upon Engel's classification of malocclusion, as I told you, most of the orthodontists worldwide, they follow it. There is no evidence to suggest that this arbitrary ideal occlusion provides significant health benefits, or that it significantly improves the oral function. Engel's classification is not based on a verifiable biologically based constant. It relies on dental intercuspation or static occlusion, which takes place between 15 to 30 minutes per day. If you remember, I showed you in one of the lectures the Possel's envelope, and I told you that most of the time the jaws are separated, and when they are even functioning for a very brief period of time, our upper and lower teeth, they come in contact. So if we take the mean out of 24-hour cycle, it is only 15 to 30 minutes when our teeth, they come in contact. Etiology of malocclusion, in most instances, it is a developmental condition. Rarely it is a pathological condition. We are talking about deviating from Engel's class 1 molar relationship and skeletal 1 relationship results from a complex interaction among the multiple factors. And occasionally, there is only a one specific cause. There would be multiple causes. So, etiology of malocclusion, we can say that it is multifactorial. Well, amazingly, if we rely on the Engel's classification, then 65% of the population, they are having malocclusion, out of which we only know 5% of the cases that why the malocclusion is occurring. Rest 60%, we are not aware of the etiology. Well, in order to find out the etiological factors, many scientists, they worked over the period of time, and like Andrews, Roth, Esch and Ramford, and Rinchius et al., they all introduced the functional concept of occlusion, and that challenged experience-based rather than the evidence-based concepts which were first proposed by Edward Engel. Edward Engel, just looking at the patients, at normal individuals as well who were not patients, and he proposed that, okay, this is the class 1, this is the normal occlusion, this is the distal occlusion, this is the meso-occlusion, class 1, class 2, and class 3. Well, Andrews, he brought his own concepts of occlusion with his 6 keys to the normal occlusion. Roth had also worked on the dynamic and functional. Similarly, all other scientists. So over the period of time, several classification methods have been proposed to categorize the etiology of malocclusion. Well, all of us, and even the scientists who worked on it, and all of us, the dentists and all the orthodontists, everybody, these people who are working on these scientific grounds, researchers, we are having a consensus that definitely there are some inherited and there are some acquired factors. Inherited, they are predetermined, we call those genetic factors. Whereas acquired factors, these are the environmental factors. At times, the environmental factor would be there, but if the inherited or the predetermined or genetic factor is missing, then usually the environmental factor is not going to be that much pronounced. Whereas if there is an inherited factor present, then it is going to be there. Like, say, for instance, a patient comes to you with malocclusion, it is needless to say that there would be some genetic factor. There will be a genetic factor until unless some very specific environmental factor would be there. In 1956, McCoy and Shepard, they have classified the factors as direct, the determining, and the indirect, which were predisposing. Both the factors, the direct and indirect, they were actually interdependent and they were working together. In 1972, Robert Moyers, he proposed certain factors and he classified as heredity, developmental defects, trauma, physical agents, habits, diseases, malnutrition. He also, in hereditary, he said that there are a part of heredity are not only the genetic factor, but also the neuromuscular factor. And even the tongue thrust swallow and the thumb sucking, he classified under the neuromuscular influences. Salzman, he just broadly classified as prenatal factors and as postnatal factors. Well, Graeber, he typified as general the extrinsic factors and local as intrinsic factors. In our part 2, we will go into the details like how the Moyers he classified the uh, different classes, like from A to G. He had what were the basis of his classification, what were the basis of Graeber's classification, and what are those factors. Well, just to give you an idea, Graeber, heredity, congenital defects, environmental, predisposing metabolic climate and disease, diet, abnormal pressure habits, posture, and trauma. Well, finally, in like uh, last couple of years, we can say like maybe 20, 25 years, we have now these three causes which we have. There is a consensus that okay, these are the three major causes, and the classes, like all other problems, they will be typified under these, classified under these. Ackerman and Profit, they have proposed it: specific causes, genetic influences, and the environmental influences. For specific causes, Ackerman and Profit propose disturbances in the embryological development, skeletal growth disturbances, muscle dysfunction, acromegaly, and disturbances in the dental development. Environmental influences include masticatory function, oral habits, respiratory pattern, etc., etc. Well, the respiratory pattern, like many people who have mouth breathing problem, probably they are not going to develop the malocclusion at all. And when a person has a specific type of facial appearance, but if you will ask the, like you will go into the history, there will be a chance, okay, you look at that person, you say, okay, there would be a chance that this person is having a respiratory. But when we look into their history, we will find out, okay, there is always a genetic influence which has made this respiratory pattern to act on the developing occlusion and made it a malocclusion. These classifications exhibit the complexity and varying interdependence of both hereditary and environmental factors. We will discuss these in detail in our next lecture. Next lecture is going to be slightly longer. At the moment, just I wanted to give you a brief introduction. Keep in mind the genetic factors and the environmental factors, they work hand in order to produce the malocclusion. But at times there are certain specific genetic factors are there, and at times there are certain specific environmental factors are there to produce the malocclusion, which would be not dependent on, like if there will be some specific environmental factor, probably it won't be dependent on the genetic factor, or if there is some specific genetic factor, probably it won't be dependent upon the environmental factor. It will invariably going to produce the malocclusion. So hopefully you would have enjoyed this lecture, and your feedback is always welcomed. And any other topic, like next week we are going to do the part 2 of this lecture. But after that, whatever the topics you want to discuss, like maybe growth and development, postnatal growth, etc., just let the uh, owners of this channel know, and they will contact me, and definitely I will be back with those topics which you really want to listen and you want to discuss. So over here, for we are done with for today's lecture, and inshallah tomorrow, like the next week, on Monday, we will be doing part 2 of this lecture. Thank you very much.
Thank you, sir. Thank you so much for your time.
Thank
Allah
you.
Hafiz.
Allah Hafiz.